Hi, my name is Siwan Kaur, first year internal medicine resident at Michigan State University. Today I'll be presenting a case of ischemic colitis in severe COVID-19 and unforeseen and catastrophic gastrointestinal complication. As we all know, COVID-19 is primarily a respiratory disease, but atypical presentations, extrapulmonary manifestations, and complications have been reported. GI manifestations and complications are increasingly being recognized as part of the disease spectrum. In fact, GI symptoms have been described in 10% of patients. In most cases, symptoms are mild and self-limiting with diarrhea, nausea, and vomiting, but it can be otherwise. Here, we're reporting a case of ischemic colitis presented as a GI complication of severe COVID-19 pneumonia. A 60-year-old male with past medical history of diabetes presented with shortness of breath for 2 weeks. He was admitted to the medical floor for COVID-19 pneumonia complicated with acute hypoxic respiratory failure. He received IV dexamethasone, IV remdesivir, and convalescent plasma per hospital protocol. However, he developed worsening respiratory failure and was intubated on day 20 of hospitalization and was transferred to ICU. In ICU, he developed hypotension, fever, and worsening leukocytosis, requiring norepinephrine infusion, and was started on broad-spectrum antibiotics. On day 5 of ICU, physical examination reviews distended and tense abdomen. Subsequent CT abdomen pelvis shows dilation of the ascending, transverse, and proximal descending colon, pneumatosis of cecum and ascending colon, and presence of free fluid in the right lower quadrant. The patient underwent emergency exploratory laparotomy and subtotal colectomy, which reviewed ischemic bowel from cecum to mid-descending colon. Unfortunately, on day 7 of ICU, he developed multi-organ failure and expired briefly after transition to comfort care. On Figure 1, CT abdomen pelvis shows a dilation of the ascending and the descending colon. On Figure 2, the presence of free air was identified, showing there's a presence of pneumoperitoneum. On Figure 3 and Figure 5, there's bowel wall thickening and fat stranding along the posterior wall of the cecum and ascending colon, suggestive of inflammatory changes. And on Figure 4 and Figure 6, there's punctate foci of free air next to the cecum and proximal ascending colon, suggestive of pneumatosis and perforation. There are 4 postulated pathological mechanisms for ischemic bowel in severe COVID-19 infection. Number 1. Coagulopathy, hypercoagulable state induced by systemic inflammation and cytokine storm resulting in micro and macro circulation thrombosis. Number 2. Direct invasion, the expression of ACE2 on colonic cell of bowel. The target receptor for SARS-CoV-2 results in intestinal tropism and direct bowel damage. Number 3. Vascular endothelial dysfunction. So this happened because the vascular endothelium expresses ACE2, result in endothelial self-tropism of the virus and subsequent endothelial dysfunction resulting in vascular thrombosis. Number 4. Non-occlusive colonic ischemia. Shock, hemodynamic compromise leads to inotrope use, and this ultimately causes vasoconstriction of small vessels, leading to compromisations of the perfusion of colic tissue. In conclusion, the exact pathogenesis of ischemic bowel in severe COVID-19 infection is still unclear at present. Life-threatening GI complications of COVID-19 infection, such as ischemic bowel, remains a diagnostic challenge, especially in intubated and sedated patients. Due to the high mortality of ischemic colitis, it's imperative to have a very high clinical suspicion and low threshold for abdominal imaging in severe cases of COVID-19 infection. Early diagnosis and treatment is paramount in order to reduce mortality and morbidity in severe COVID-19 infection. That concludes my presentations, and thank you for listening.